Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is drug allergy. So what is a drug allergy? This is an allergic response to exposure to a given drug. It is divided into 4 categories as per the immunological response and hypersensitivity reactions. Approximately 1 to 10% of medication prescriptions lead to some form of a drug allergy. So here we have the immunological classifications of hypersensitivity, something which we will delve into in further presentations. But just for the purpose of this presentation, we're looking at the class subtypes in relation to drug reactions. So if we first of all look at hypersensitivity class 1 in the left-hand column, this is an immediate hypersensitivity reaction and is IgE mediated, and the clinical picture is that of anaphylaxis, urticaria and angioedema, and bronchospasm, and a common example of this is allergy to penicillin. It's really important when taking a history, so for example in PACES, when a patient tells you that they have an allergy to a medication such as penicillin, to find out exactly what type of reaction this is. So is it a type 1 hypersensitivity reaction, which involves anaphylaxis, or is it an intolerance, such as that which may cause nausea, or is it something else, such as a rash or vomiting? If you want to find out more about anaphylaxis, please click on the link to our previous video, which covered this in much more depth. Next row shows hypersensitivity class 2, and this is cytotoxic antibody related. An example of this is also penicillins and heparin, and it causes hematological cytopenias classically. A class 3 hypersensitivity reaction would be immune complex mediated, and this can lead to drug-induced lupus and vasculitis, and examples of these are minocycline and carbimazole. If you want to know more about drug-induced lupus, just click on this link and it'll take you back to our video in our rheumatology series, which talks much more about the drugs and the types of reactions that this causes. And finally, type 4 is T-cell mediated. This causes a contact dermatitis and can cause an interstitial nephritis. Classical examples of these include topical antibiotics, nonsteroidal anti-inflammatory drugs, and halothane. So the signs and symptoms of a drug allergy are very similar to those that we would associate with an allergy in general. So these include lip tingling, wheeze, or stridor in severe cases, facial, tongue, and throat swelling, which can also involve angioedema, as well as syncope, which is characterized by hypotension and may be part of a wider anaphylactic reaction. Urticaria will also be seen. It does, however, depend on the type of hypersensitivity and the reaction, as well as the drug, as to exactly which signs and symptoms you will see in an individual patient. So it may well be that you may have a history in your PACES exam of the aftermath of an allergic reaction to a drug, or it might be part of the history, particularly when you're asking about current medications and drug allergies, that you have to elicit this information. So it's really important that you take a detailed drug history, particularly in clinical practice, and then a skin prick test may be indicated, including a challenge. The following agents can be detected on skin prick testing, and these include antibiotics such as penicillins and cephalosporins, anesthetic agents such as neuromuscular blocking agents and thiopental, enzymes such as streptokinase, chemotherapeutics such as cisplatin, as well as others such as insulin and latex. It's important to note that the IgE level is unreliable in drug reactions overall. The management of an acute drug reaction is as per anaphylaxis, as well as long-term avoidance of the trigger. A medic alert bracelet may be indicated, particularly for patients who do have recurrent hospital admissions. Patient education is, of course, paramount, and they should be aware to tell their healthcare providers that they cannot have certain drugs because of these reactions, and it's important to record the nature of the reaction in the patient's medical history. In milder reactions, the use of therapeutically important drugs may be justified if used cautiously and with monitoring, for example, in life-threatening circumstances, but this should be decided on a case-by-case basis. So let's try a question. A 65-year-old patient currently on chemotherapy for lymphoma presents feeling generally unwell and with hemodynamic instability. He is found to have cytopenias with a neutrophil count of 0.1. He has a temperature of 39.4 degrees Celsius on the news chart. He informs the IMT2 clerking doctor that he is allergic to penicillin, with a previous reaction comprising an urticarial rash over his limbs without airway compromise. Which of the following statements is incorrect? So, these are your options. A broad-spectrum intravenous antibiotic is indicated. Tazocin must be avoided at all costs, given his previous anaphylactic reaction. Antibiotics should not be delayed until blood culture results are available. He should be closely monitored if he receives a penicillin preparation. Oral antibiotics is unlikely to be therapeutically suitable in this case. So I'll just give you a minute to think about that. So this is a case of neutropenic sepsis on a background of lymphoma and chemotherapy. So we already know that he's quite unwell and will require broad-spectrum antibiotics at the very least. So we are looking for the incorrect statement. The first answer, therefore, is correct. A broad-spectrum intravenous antibiotic is indicated. The second answer, tazocin must be avoided at all costs given his previous anaphylactic reaction. Now, if we read the vignette, we can see that he has not, in fact, had an anaphylactic reaction. His previous reaction comprised a rash, and we are told specifically that there were no signs of airway compromise, as would be seen in an anaphylactic reaction. So it's possible that B may be the incorrect answer, but let's look at all of the others. Answer C tells us that antibiotics should not be delayed until blood culture results are available. This is definitely correct. He should receive antibiotics as soon as possible. Answer D, he should be closely monitored if he receives a penicillin preparation. Now, this is most certainly correct because we know he's had a previous adverse reaction to penicillin preparations, which comprised a rash, but it did not comprise anaphylaxis. However, we do need to monitor him carefully, just in case the reaction this time is different, if at all present. Answer E is that oral antibiotic is unlikely to be therapeutically suitable in this case. This is also correct because he has neutropenic sepsis on a background of immunosuppression and is very unwell with it. So he really does need IV antibiotics and admission. So in this case, we come back to answer B, and this is incorrect. And so we can select this for the answer. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.